So we're going to learn about cardiomyopathies. So what are cardiomyopathies? Cardiomyopathy, it is a myocardial disorder. What is a myocardium? Myocardium is the heart muscle. So as you know, heart has three layers. One is pericardium, which is the outermost layer. Then comes the myocardium, which is a muscular layer, which has the cardiac muscles, which is branched and is a syncytium, right? And it has striations. So this myocardial muscle, and then we have the endocardium, which lines the valves also, and it is a main reason for vegetations in rheumatic heart disease. So we just learned that there are three layers of the heart muscles, out of which myocardium is the one that we are concerned about right now. So in a myocardial disorder, in a cardiomyopathy, there can be a structural deformity or a structural disorder, or it could be something wrong with the function of the myocardium. So a functional disorder. So the cardiomyopathy is a myocardial disorder which can be a structural or a functional disorder. So there are three types. Okay, well, when we talk about cardiomyopathy, and when I just gave you a generalized definition, we usually will also consider other heart diseases which affect the myocardium, like coronary heart disease, hypertensive heart disease. These also affect the myocardium. But cardiomyopathies do not include the following diseases. And what are those following diseases? One is a coronary artery disease or coronary heart disease. Then we have hypertensive heart disease, a valvular heart disease, or a congenital heart disease. So none of this comes under cardiomyopathies. So rest all of the heart diseases which affect the myocardium except these four comes under cardiomyopathies. So the types of cardiomyopathies. So cardiomyopathies are broadly divided. There are many other types of myopathies as well, other than the three types that I'll talk about right now. So cardiomyopathy is broadly divided into dilated cardiomyopathy, hypertrophic cardiomyopathies, and we have restricted cardiomyopathies. So what are the three? Dilated, hypertrophic, and restricted cardiomyopathies. So what about these? So first we'll talk about dilated cardiomyopathy. So what about dilated cardiomyopathy? The reason why I'm talking about dilated cardiomyopathy first is because it is the most common type of cardiomyopathy. Since it is the most common type of cardiomyopathy, we will be talking about it first. So as the name suggests, dilated cardiomyopathy is usually dilated ventricles. Left ventricle more than the right ventricle. So when the ventricles, they enlarge in size, they not only enlarge but they actually dilate. Now what does this mean? Dilation means like when you put air into a balloon, the thickness of the balloon, it will decrease as the air inside the balloon increases, right? So the same funda works here. So when a ventricle dilates, for example, the thickness is this much in a ventricle right now. But as soon as it dilates, the thickness will reduce. But if you weigh this dilated ventricle, the weight will be more. So what we can say is dilated ventricle, the weight will increase, but the thickness will decrease. Why the weight increases? Because the capacity of the ventricle will increase, so there'll be more blood collected in the ventricle, so that's why the weight will increase, while the thickness of the ventricle, on the other hand, it will decrease. So is this clear? So next we will talk about the causes of dilated cardiomyopathies. So we can divide the causes. So when we talk about the causes, we can broadly divide the causes into infective and non-infective causes. So inside the infective causes, there are many entities that can cause infection in a human, as we all know. One is virus, so it can be a viral cause, or it could be a bacterial cause. So under viral and bacterial, we can learn in viral viral is the most common cause of infective entities. And then we have parasitic infections also. Under bacterial, we have diphtheria, and we have Lyme's disease. Under parasitic, we have toxoplasmosis, and Chagas disease. So these are the few infective causes of. What is the takeaway point? Most common infective cause is a viral cause. Okay, so do not forget this. So most common infective cause is a viral cause. Now we have non-infective causes as well. So in non-infective causes, there can be granulomatous causes. In granulomatous causes, we talk about sarcoidosis. Then we also talk about eosinophilic myocarditis. Eosinophilic myocarditis. Then we have myositis, collagen vascular diseases, all these things. Then we have certain toxins as well. So how do toxins affect? So one is alcohol, which is the second most common cause. The first most common cause was viral causes. So second most common cause is alcohol. Other than that, we have catecholamines. So in excessive stress, there can be dilated cardiomyopathies. And then we have cocaine. And there are 3 drugs that we need to know. There's a mnemonic to follow, that is DDT. DDT, you all know, is a pesticide. So the 3 drugs is doxorubicin. Then we have daunorubicin. And then we have trastuzumab. So these are the 3 important drugs that come in the exams that you need to know, which can cause dilated cardiomyopathies. Okay, so the takeaway points are: viral causes are the most common cause, and the second most common cause is alcohol. Okay, other causes can also be there, one of which is selenium deficiency. So selenium deficiency is also an important cause. Then we have magnesium, calcium, and carnitine deficiency. Endocrine causes can also be there, like if somebody has thyrotoxicosis, they can have dilated cardiomyopathies. Obese people are more prone to having cardiomyopathies. Hemochromatosis, which is deposition of iron in the ventricles. So hemochromatosis can also cause dilated cardiomyopathy. Genetic causes can be there. And then we also have very important peripartum cardiomyopathy. So one important thing is I just talked about two disorders, one being hemochromatosis and sarcoidosis. So hemochromatosis, more of dilated cardiomyopathy is seen when there's a hemochromatosis. But whenever there is sarcoidosis, more of restrictive cardiomyopathy is seen more than that of dilated cardiomyopathy. Okay. So in both the diseases, we see what? Both restrictive cardiomyopathy and dilated cardiomyopathy. But in case of hemochromatosis, the dilated variety is more common than the restrictive variety, while in sarcoidosis, the restrictive variety is more common than the dilated variety. Now, what are the clinical features in dilated cardiomyopathy? So, the first important clinical feature is heart failure. So, whenever there's heart failure, because there's too much of dilatation, so the heart will not be able to pump, its muscles will become weak, so the heart will not be able to pump, and that will essentially lead to heart failure. So, if somebody has heart failure, the classical symptoms are dyspnea, PND, which is paroxysmal nocturnal dyspnea, pedal edema, and of course fatigue. Because whenever the person exerts or exercises, there will be more blood requirement, blood oxygen requirement to be specific, and so this will demand more cardiac activity. But since the heart is in failure, it cannot fulfill the demand. Heart cannot fulfill the demand, as a result of which fatigue occurs. So this is a mechanism of fatigue: dyspnea, PND, pedal edema, and fatigue. So this is one symptom. Then we have, on examination, what will you see? Now, whenever there is a heart failure, okay, so whenever there is heart failure, especially the left atrium and the left ventricle, so you know that the left atrium it is connected to the lungs, right? So oxygenated blood, it comes from the lungs, enters the left atrium, then it goes to the left ventricle, and from there it exits through the aorta. So this is very important, because whenever there is dilatation of the left ventricle, so if there is any dilatation of the left ventricle, or if there is any heart failure symptoms, there will be pooling of blood in the left ventricle. If there is pooling of blood in the left ventricle, there will be backflow of blood, because of which there will be pulmonary edema in the lungs. And if there is pulmonary edema in the lungs, what are the clinical findings? You will find what? Crepitations on auscultation. Also, because of right heart failure, because you know that the most common cause of right heart failure is left heart failure. So in right heart failure, what happens is there will be raised JVP because of backflow of blood into the jugular veins. Then we also see S3, heart sound, and we also have a displaced apical impulse. So because there's dilatation, what will happen? It will be displaced. Mid-clavicular line, laterally and below. So the best prognosis in dilated cardiomyopathy, it is seen in peripartum cardiomyopathies. So these patients who develop dilated cardiomyopathy during pregnancy, they recover quickly. So what do you see on echo? So whenever you do echo, you will see a dilated ventricle, wherein the annulus also gets dilated. Annulus is what? So if this is the annulus on which the valves, they are attached. If this is a dicuspid valve. These are the cusps, okay? And this thing to which the cusps are attached, this is called the annulus. So if the ventricle which is attached to the annulus, it dilates, naturally the annulus will also dilate. So on the echo, we will see a dilated annulus. Also, prognosis depends upon the ejection fraction. So, ejection fraction is inversely proportional to the mortality rate. That is, more the ejection fraction, less is the mortality rate.